Cotrimoxazole is an antibiotic which has been present for a long time, more than 50 years now. It's composed of trimethoprim and sulfamethoxazole, two agents, both of which interfere with folate metabolism. The former inhibits dihydrofolate reductase and the latter is a competitive inhibitor of PABA. It is believed that this provides them synergistic activity and also has a potential to make them bactericidal agents. They are available in 1:5 strength, and when administered as such, they reach a 1:20 strength in the tissue, which is the optimal concentration at which they work. They are active against both gram-positive and gram-negative bacteria and historically has been used for renal infections, GI infections, lung, throat and ear infections. But the problem was growing resistance and availability of alternative agents which were considered more safe, and thus they have become a second choice when there is an allergy to beta-lactams in many of these infections. The major problem was the adverse events, which are not insignificant. You can have allergic skin reactions, you can have hemolysis in G6PD deficient patients, there could be allergy to the sulfa component, pancytopenias and hepatitis, which is why we are using alternative agents which we consider as safer. It's still the first choice in pneumocystis, and in toxoplasma also we generally use pyrimethamine and sulfadiazine there, but to say antifolate drugs are used in toxoplasma. They also used for prophylaxis in HIV population, and now that window is increasing even more. Even with higher CD4 counts, we are using prophylaxis with cotrimoxazole. The interest which is now being regenerated is when organism resistant to current agents is encountered, both for gram-negative organisms and for gram-positives like MRSA, where it might have activity. It is available as oral tablet with a strength of 80 to 400 and a double strength tablet which is 160 by 800. In suspension, it is available as 40 by 200 per 5 ml. So a 10 ml suspension would be equivalent to one oral tablet. And in IV formulation as 16 by 80 per ml. So a 5 ml will be equivalent to a normal oral tablet. The dose, we use it least in UTI. So the normal strength, one tablet twice daily. In other infections at other sites is generally the double strength twice daily or two tablets of the normal dose twice daily. The highest dose is what we use in PCP, 20 milligrams of trimethoprim equivalent per kg body weight. So for a 60 kg plus, it would be something like 2 double strength tablets 4 times a day. Trimethoprim is excreted unchanged in urine and requires dose modification in the presence of renal failure. Sulfamethoxazole does undergo hepatic P450 mediated metabolism, but the metabolites require dose modification because they are renally cleared. So in the presence of renal failure, when the creatinine clearance is less than 30, we need to cut down on the dose, and they might be avoided altogether with a creatinine clearance of less than 15.